thickening of the wall layers, that's it, everywhere in the gut tract, predominantly in large intestine and in small intestine as in 604. You must speak with the patient and palpate physically, and only then apply ultrasound and other modalities thereafter, like with 505. Delicate structures you have to deal with, as seen in the pre-war market in Aleppo in 2004 in figure 506, and in 507 echoscopia of the small intestine loops affected by an active Crohn's disease. The same is seen in 508, diarrhea accompanied by heavy cramps in this case. And once more, you find it as a similar case in 509 and in case 510 as well. Different cases, all of them, with a different, so similar imaging. But be careful, here in 511, this wall thickening turned out to be malignant, whereas in 512, stenosing Crohn's disease had led to an ileus of the loops further down in the GI tract. A similar feature originated in 513 from small intestine involvement in colonic diverticulitis. A classical ileus terminalis, again in 514, with the typical thickening of the wall layers. And in 515, pictures down right show a self-limiting diarrhea. Clinical appearance is decisive. This holds true for case 516 as well, thickening and congestion of small and probably large intestine as well. Whereas in case 517, clinical history and further course were rather favoring an ischemic episode. Look at the large gut wall, normality in hydrocolonosonography at Limberg, and confer with the pathology in 519 with inflammatory swelling of the wall layers in ulcerative colitis. But let us consider thickening of the wall layers in other examples as well, like for example in case 528 with the reflux esophagitis, or in case 520b with a massive gastric retention. See also 5.1.2 in BETTER-ULTRASOUND. In case 521, thickening is caused by seldom percutaneously visible esophageal varices. Remember the color knob. Here in 522, harmless lipoma of the stomach was found only needing no more, but surveillance only. And in case 523, a seldom reason 2 was found a gastric amyloidosis observed unchanged for decades. No softness in spontaneous elastography. This again is different in case 524, an anti-adenocarcinoma with a local sickling and partial invasion of the wall layers. And here in case 525, please note the open and normal pylorus, which is in this very moment gas-filled. It is included firmly in case 526 as an observation of the normal, with a tiny arteria gastroduodenalis and a normally thick vena lienalis. Like in 527 and in 528 as well, with different amounts of shadowing gas, different cases of normality as well. At 29, however, a pathology is depicted swelling of all the duodenal bulb and transient inflammation. As normal again, please note in 530 the liquid-filled duodenal sea surrounding the head of the pancreas. And the slightly swollen outlet in figure 531, the outlet of the duodenal bulb. In 532, thickening of wall layers again is due to Crohn's disease. Note the loops being hit in a transverse fashion. In 533, note the inflamed and swollen plicae in the course of a Crohn's disease as well. And an even more pronounced fold swelling in 534. Whereas case 535, C513, is repeated in different sections and different zoomings because it is so impressive. In case 536, it was a non-Hodgkin lymphoma of the small intestine found as underlying reason for the thickening of the wall. In 537A, you find a vivid peristalsis in the case of Crohn's disease, and in B, again, you find two well-visible folds and enhanced liquid filling. And in case 537C, you note both swollen and normal intestinal loops. Whereas case 537D demonstrates, aside the thickened layer, an impairedly slowed peristalsis of the 538 is another case of impaired perfusion in the sense of an partial arterial occlusion and subsequent ischemia. This was suspected in this case 539 as well, since the patient investigations neglected further, the case could not be cleared. In case 540, however, history was clear and irradiation. In 541, an aerobilia and later on ileus were followed by diffuse abdominals. Again in 542, enhanced water filling, thick plicae, and slight ascites, do not press with the probe, are typical ileus features. And in 543, a pathognomonic washing machine peristalsis, pathognomonic for a screw. This in 544, however, was a self-limiting transient inflammation only, lasting few days merely. Incidentally, here in case 545, an asymptomatic hepatic arterial aneurysma had been noted with a slight intrahepatic congestion in segments 2 and 3. In 546, a postoperative status after ileocecal rejection is shown. This is true in another, a bit more difficult case in 547 as well. Please note in 548A the marked lymphadenopathy caused by intestinal inflammation. This is true in 548B as well. Case 549 shows another case of self-limited enteritis, and in 550 another marked lymphadenopathy case can be noted. In 551, you notice typically reflex-rich and big lymph nodes intestinally and hilary in a Book's disease. And in case 552, you see another case of Crohn's disease with affected and with unaffected small intestinal loops. It is Crohn's disease as well. In 553, note the serious situation of the small intestine, and indeed it was leading in the end to an operation. In 554, you see a typical complication of long-standing IBD, a primary sclerosing cholangitis PSC. As well, intrahepatically in 552 and in 556, arterial occlusion again with similar morphological features. And in case 557, a classical fistulization between small intestinal loops is seen. In 558, it is the urinary tube distended, leading to a grade 2 congestion of these ducts due to a metastatic ureter occlusion. Similarly, in 559, note the puncturing fine needle tip in anterograde urography. 560 shows the typical features of an incarcerated inguinal hernia. Here in 561, fistula and the course of Crohn's disease are shown in all their diversity. And here in 562, please note the influx of floating gas bubbles into the portal system, indicating a serous abscess complication, shown intrahepatically in 563. This is usually misinterpreted as apnea and static CT scanning, as you can see in 564. Here in case 565, a Barber demonstration is found with an echo-free and non-perfused abscess. Another abscess reaching up to the skin is here depicted in case 566, well visible even without bubbles. Another case of mesenteric ischemia with thickening of the wall layers is seen here in case 567, whereas here in case 568, a purulent loop abscedation is seen, which leads to a sort of abscedation as well. Different myoma are shown here in 569 and 570, and the further course has to be decided by the gynecologist. As well as in the cases 571A and B, asymptomatic as they are, further treatment should be directed by the specialist, especially what to do about this cystic malformation. We come back in case 572 to Crohn's disease and fistulization, not so easily detected. And again, we come back in 573 to another neuroendocrine tumor. And the same case in near side, once more in 574, some gentle pressure of the probe is needed to press away disturbing gas. Here in case 575, we already must notify neuroendocrine metastasis of the liver, and in 576, this is an aortic prostasis having led to diffuse abdominal pains previously, whereas in 577, a perirectal phlegmona is complicating a Crohn's disease course. Ascites here in case 578 probably is of a malignant origin. Please note peritoneal nodularity. In case 279, it is again an ischemic cause in a heavy smoker leading to intestinal ischemia with a somewhat monomorphous answer of thickening of the wall layers. And non-specific enteritis, like here in case 580, always must be taken into consideration. And once more, a classical ileitis terminalis Crohn in 581. Please note the bars marking the wall thickening. Color flow reveals easily in case 582 the true nature of these space-occupying lesions. They are profuse intestinal varices. 583 and 584 show a leiomyosarcoma, the latter in old-style barber technology. 585 is the specific gallstone ileus feature we wanted to come back to. In 586, it is again the clinical and echographical typical feature of an unspecific enteritis. This is true in case 587 as well, a self-terminating diarrhea. And in 588, a non-specific self-limiting enteritis leads to a special nice depiction of the fungus folds. In 589, the enhancement in small intestine loops water-filled leads to a technical visualization problem. And in case 590, please note the stenosis arrows and the thickening of the layers. 591 shows like the foregoing case 589 and a small intestine ileus. Thickening of the wall layers here in case 592 shows the seldom duodenal manifestation of Crohn. Acute cholecystitis of lithogenic origin in case 593 again. Note please vicinity from gallbladder and bowel. In 594, rare but possible, a carcinoma of the small gut leading to weight loss and constipation. In 595, again, the intimate neighborhood of duodenal bulb and gallbladder are pronounced once more again, and again the clinical active Crohn is featured in case 596, loops being differently much affected. This is true again for case 597 with again thickening of the wall layers. Note here in 598 specifically how detailed surgical errors of performance can be featured by echography. Endoscopic treatment was successful. This thickening of the loop walls in case 599 was not due to IBD. An ileus operation was foregoing the other day. This case 600 was classified as Crohn of the ascendants of high activity. And here in case 601, another severe case of ileitis terminalis with all features already mentioned repeatedly is seen. Also here in this case, in the already known case 602, which is repeated willingly because it is so impressive. This is true in case 603 as well, repeated because of its typical features. In case 604, it is, however, more clinical, an umbilical herniation in its real-time echographic appearance. This differential diagnosis in 605 and 606 meets the patient group of warfarin patients. It may start dramatically, but as a rule is simply waiting the method of choice. As a differential diagnosis must as well an umbilical herniation be taken into consideration, as here displayed in case 607. In case 608 again, intestinal ischemia is difficult, sometimes enteritis-like features only. This ileus in case 609 needed operation. In the end, it turned out to be a chronic ileus due to adhesions. This was also true in case 610, needing operative intervention in the end. And the same is true again in case 611, which was as well operated upon in the further course. In 612, we couldn't find a definite diagnosis in spite of this impressive feature. This was different in case 613. Here it was an intestinal polyp obturating and it had to be removed surgically as well. 614 again is different and repeated on purpose. Notice please the two types of loops, IBD affected and normal ones, slightly compressed by the first type. Different methods give different results, like endoscopy and X-ray. 615. This tumor near the valvula should not be punctured, as a mucocele it has the risk of spreading in the sense of a pseudomyxoma peritonei, and we end up with a normally functioning valvula.